like to request our first panelist, Ashish sir, and our judge, Bhattacharya sir, to proceed with the question.
So welcome both the teams, team 1 and team 2. And the way I like to pose these questions will be that I'll ask a question from team 1 and then I'll ask the similar question from team 2, and continuously will repeat those questions so that you will have a similar kind of order of history telling or order of the treatment which is to be done. So we are starting with team 1. Team 1, is it audible?
Yes, sir.
Okay, so you look at this picture and you've seen the history. It's a 62-year-old female with repeated infection and multiple times IND had been done and treated conservatively in the 10 to 8 leaves area. So what is your provisional diagnosis in this case once you have seen this?
Only 1 minute time will be given.
Post-infective non-healing ulcer over posterior aspect of the distal 1/3 leg.
Okay, anything more you want to tell? Just in the diagnosis, you have to tell the diagnosis only. So I'll help you out. This is the first question. So this can be just an infected ulcer, infected non-healing
It
ulcer.
can. If you want any information, you can pass on the question to the second team, sir.
Yes. So because this was the first, so I just told them how to answer. Now, second team, please. So what is your
Will you
provisional
give
diagnosis here?
How many marks for the question, sir? 2 marks?
1 mark.
Answer. 1 mark. Okay.
Yeah. Team 2.
Team B.
Team B. What is the provisional diagnosis?
Any improvement or anything else you want to give the information, please give. Team 2.
Team 2.
Can we know whether the patient is diabetic?
Non-diabetic.
Okay. Post infection, non-healing ulcer over right posterior ankle, right ankle posterior aspect with tendinoachilles exposed.
Post-infective.
Status post multiple.
Status post incision and drainage.
Okay. So I'm 1 marks. Going back to team 1. Team 1, is it audible?
Yes. Yes, sir.
Okay. So can you tell us 4 points regarding history and finding to support the diagnosis which you have made? Because why I'm mentioning 4, because there are 2 marks for that. So we'll give you half marks for each finding. The history can be positive or a negative history related to this, because you're just seeing an image. So you can tell whatever you made you think that this is an infective ulcer, or if you have to rule out a particular ulcer also type of ulcer, you can tell in history and examination.
Since he underwent multiple INDs, so for the infected lesion, so it is post-infective, and duration is since 8 months, so it is non-healing. As well as you can see the peripheral discoloration around the leg, so might suggest the excoriated skin, which is might be the venous pathology.
So, what did you say last line? It was not clear. You are suspecting a venous pathology also?
Yes.
Team A, you have to prune up your audio. You are not so legibly audible here.
Just come close to the mic.
Either come close to the mic or prune up your audio.
Yes, sir. Am I audible?
You are audible.
Yes.
Yeah,
Tell the
proceed.
4 points which sir asked for. Now
Yes.
clearly.
Sir, since she underwent multiple INDs, so it is infective as well as the duration is the ulcer is since 8 months, so it is non-healing. As well as the surrounding region, there is discoloration, black discoloration, which are suggestive of excoriated changes, which is more toward venous pathology. Would be venous.
Okay.
1 point, sir.
So I think
You are not satisfied with the answer, you can
Two.
go to team 2, sir.
yeah. So I think two marks. Most of these points are okay. Team 2, Team B. So add find more points in your history and finding to support this diagnosis, or if you now think that it can be something else, you can add points to that in terms of history and examination.
Hyperpigmentation surrounding the scar also and lipodermatosclerosis point towards the venous pathology. So it's a venous ulcer.
Okay.
You have to tell 4 points, 2 in favoring the 2 in history and 2 in examination to favor your diagnosis. Whatever. No. Since you are now thinking about this to be a venous thing, so at least 4 points, 2 history, 2 examination to support your diagnosis.
Long-standing non-healing ulcer point towards in history. Long-standing non-healing ulcer is suggestive of probably non-healing venous ulcer, and in examination, the distal third of leg and hyperpigmentation in surrounding skin,
And the ulcer looks like it has a sloping margin.
sloping margins, sloping edges.
Does it look like a dry ulcer or a wet ulcer?
Like a dry ulcer. I can't see any slough. Surrounding area.
Granulation.
There's granulation. It looks like a dry ulcer.
Okay, so I think 1. Okay, so 1 mark to team B. So coming to team A, now what are the investigations which you are planning to further reinforce your diagnosis and to work up a plan?
So firstly, I will take the history of skin or any chronic disease. Then I will
Please come close to the mic.
the first. I will ask for the history of any smoking or any chronic disease like diabetes mellitus. Then I will proceed with the clinical examination for the venous pathology, like Trendelenburg test, then Pigan test and Cortese test, then multiple tourniquet test for the perforators. After that, I will look at the look for the radiological investigation, in which I will go for the arteriovenous Doppler bilateral lower.
So question passes to team B. Any more investigation you want to do?
But then what they said, sir. No, sir.
So we give 1 mark to team
Okay.
KGMU. and this was a past question. So team B. So team B, since you are now thinking about vascular lesion, but it can be any other ulcer also. So if you find this to be any other, if you want to rule out that, what are the other investigation, basic investigation which you should do for any wound? It is not that you think of this as vascular ulcer and you start working upon it just as a vascular. It can be any other ulcer also, because history wise this patient is had multiple INDs done. So will you like any other investigations to be done?
Sir, HbA1c for diabetes, then
Random blood sugar.
blood sugar levels, then Doppler to rule out any vascular pathology, then ankle brachial pressure index also I would like to measure to rule out any limb ischemia, and history of smoking or any other comorbidities for peripheral vascular disease.
Okay, so 1 mark to team B, and we pass this again to team A. So now you had some time to think of it as an ulcer. Think of it as any non-healing ulcer, which is 8 months old. So some basic other test which one should always do. Think about it.
I would like
Rule.
I would like to get a
Very basic OPD test, or what test you, these patients when come to OPD, there are some tests which you like to do.
So I would like to get a edge wedge biopsy done due to the chronic nature of the ulcer, and a culture, swab culture to detect any the colonizer.
Very good. So 1 mark to team KGME also, because this was a past. So with history and examination and some investigation, we have reached to some kind of diagnosis. See, this is all, you have just seen an image. So don't get yourself fixated to a particular diagnosis. It can be anything. It can be a very simple non-healing ulcer also. So now, since all this has been done with all the history, examination and investigation, so now we are back to team 1 for how are you going to approach? Means now the clinical part starts, that how you will treat these patients with, in terms of it has come to OPD. So how you are going to do a surgery, or before surgery, how you are going to plan it.
Wait for histopathological evaluation and the report to come. Then I will decide to excision and resurfacing of the ulcer. So we will do the basic blood workup and pre-anesthetic checkup after that.
So you mean to say your plan is excision and skin grafting?
Depends what till what level we will reach after the excision. If the tendons are exposed, then we can do the volumetric
Yes.
blood cover.
Yes. Oh, okay. So let me help you out. You mean to say you are planning for when you are planning for surgery, so it can be a 1-stage surgery or it can be a 2-stage surgery. This is what you mean to say?
Multiple steps.
You're not audible. Please, can you
Tell
come
loudly.
close?
Again, you have to tell loudly.
Multiple stage surgery, sir, I will plan.
So please elaborate on that.
After excision, I will look for the bed of the ulcer. If the granulation is present and no vital tendon or neurovascular structure is exposed, then we can graft it. Or in case if some tendon or vital structure are exposed, then we will choose for the acellular dermal matrix or flap cover. The same thing we can consider for vacuum assisted suction.
I think your network is very bad. Right?
Hello, sir. Sir, I am audible, sir.
Yeah, it's
Can you do
breaking
one
up.
thing here? Can you just disconnect your Bluetooth? I think the Bluetooth is the problem. Disconnect your Bluetooth. That is the problem, I think. You just directly speak using your mobile speaker. Now you speak.
Hello.
Yeah. Speak.
Yep.
So,
sir, after excision, I will look for the bed of the ulcer. If it is having granulation tissue, then I will go for the grafting the same stage. Otherwise, if any neurovascular structure or tendo Achilles is exposed, then we will plan for the cover. It is in the same sitting. I can go for the VAC or sir, my second plan will be the acellular dermal matrix or the flap cover.
Okay. 2 marks to team A. So coming to team B. So as team KGMU said that they will excise the ulcer firstly, and then they'll see how the bed is, and according to the bed they will plan their surgery. So as you can see, this is an ulcer which is in the tendo-Achilles area. So if we excise this ulcer, there is a chance that the tendon may be exposed. So what will be your plan when you see that although you can see the tendon, but there's still a layer of fascia around it where you think that you can do a grafting. So you should do a grafting immediately, or you should plan some other step, make it a 2-step procedure to improve the circulation.
We can apply vacuum assisted closure NPWT dressing to enhance the granulation tissue and graft, and then thereafter apply the skin graft
At a second stage.
over the exposed tendon. Or we can also use dermal matrix followed by skin grafting. Dermal matrix application followed by skin grafting.
So you will, on a tendon with some fascia, you will apply a dermal matrix, and then what you will do? You will do a normal dressing.
Yes, sir. For 3 weeks. We can either apply, if we apply matriderm of size 1 mm, then we can do the skin grafting in single stage. If we apply a thicker matriderm 2 to 3 mm or any other dermal matrix, then we have to wait for 3 weeks, then do the grafting. For the take of the dermal matrix, then we'll go for grafting in second stage.
So what is the role of dermal matrix there? Why are you applying dermal matrix? When you have a fascia there, which you feel that this is a healthy fascia, then why are you applying a layer of dermal matrix there?
For better contouring of the defect.
For more dermis overlying the tendon, so that we get basically we'll get a more supple skin and
Better pliability
of skin.
Skin pliability. And what will be your chances of graft loss since you are applying a layer of dermal matrix between already a poorly vascular tissue? You are on top of that, you are applying a layer of dermal matrix, and at the same time you are doing a skin grafting. So what will be the chances that your graft loss will not happen?
We'll wait for 3 weeks for the dermal matrix to get vascularized, then apply the graft in second stage.
So to make things clear, maybe if I understood it correctly, what you are saying is that you will apply dermal matrix and then you will keep the wound closed. You will not do anything, and after 3 weeks you'll do a grafting, or you have to do regular dressing.
We'll inspect it every few days for the vascularity, and then after completion of 3 weeks, we'll apply the graft.
So by inspection, you mean to say you are applying Integra there?
Yes, sir. Integra or BTM, sir. Biodegradable temporizing matrix.
I think firstly you told Metridum, now you are talking about Integra, and the same time you are also talking about the third one. So tell one thing which you want to do. You don't get confused. You're talking about so many options.
I would like to go, as it was a already infected wound, I would like to go for synthetic dermal matrix, that is BTM. I will apply it. Then I'll wait for 3 weeks for the second stage. Then do the skin grafting in second stage.
Sir, Ashish sir, 20 minutes are over. Ashish sir. 20 minutes are over, sir.
Okay, so we need to ask Dr. Devi few more questions, or is it over?
It's over, sir.
Time is
because
over, sir.
Time is over, sir.
Sir,
So how much mark will
team B, how
if I
many marks you are giving?
For this question, 1 mark.
1 mark. Okay, sir. So now I will request our judge one, Bhattacharya sir, to
Yes.
ask to both the teams.
This is to team A, isn't it?
Yes, sir.
So this ulcer is sitting over which structure?
Near the fascia over tender Achilles.
Do you see the
The
fascia here?
healthy, no, sir. Healthy granulation I can see.
So fascia and granulation are not same, isn't it?
Yes.
So let us call it a granulation tissue. Now, will you straightway put a graft on the top of it?
Sir, after debridement, I would like
After
to.
debridement. So after debridement, what will you see? After you have debrided the ulcer, what will you visualize underneath?
Base
There
of
is
the
hardly
ulcer.
any subcutaneous tissue there. Yeah.
Tendoachilles.
Tendoachilles. Full thickness of tendoachilles or partial thickness of tendoachilles? Because it's a chronic wound for 8 months. How will you know that it is tendoachilles?
Sir, on movement of the ankle joint, we will be able to appreciate.
So how will you move? How will you move? Patient is not going to move.
Plantar flexion passively.
Only plantar flexion?
Passively, I will do, sir, dorsiflexion and plantar flexion alternatively, and I will check the movement of the tendon.
So if you do this, what will confirm that you are seeing tendoachilles?
Gliding movement of the
gliding movement.
tendon.
So tendon needs to glide. Okay?
Yes.
Okay, I give you 1 mark. And so if the tendon is exposed, will you graft it?
No, sir. No, sir.
Because up till now you have been talking about grafting. If you graft it, what will happen? Over tendoachilles. Suppose the graft takes.
So it will lead to tethering of the tendon and.
So for the function of the tendon, what do you need?
Glide.
Gliding, a surface, a tissue which will allow it to glide. Team B, what is your idea? Passive movement shows after debridement, it is Achilles tendon moving. So what will be your management?
If tendon is exposed, I would like to go for a flap cover.
Don't you expect tendon exposure?
Yes, sir, I expect post debridement tendon exposure.
So what is your aim of treatment?
To give a good supple flap cover so that there is good gliding movements at the tendon level.
What is your goal? team A?
To make the limb functional and
Functional. He should be able to walk properly with full movement, isn't it? For that, the joints have to be also soft and supple. Okay. So now you tell me what is your choice of cover. What will be your choice of managing this wound? A graft or in something else?
Which team has to answer, sir?
this case, sir, I will choose a cellular dermal matrix for the 3 weeks, and then I will assess this and then starts.
How will you maintain the movement of the joint during that period?
This dermis will provide the pliability, sir.
So what will you advise to the patient?
The physio
Team
use
B,
physiotherapy.
during this period, what will be your advice to the patient? Okay, I move to another question. Suppose you have to give a flap.
Sir, marks for the teams for this question.
No, both the teams doesn't get any mark.
Sir, now
0. Okay.
They have not answered.
Team 2, sir.
So, if you have to give a flap cover, which flap do you think?
Sir, you asked team B, they told flap cover. So, they don't get any mark for that?
Okay, flap cover. One
They
mark.
told answered flap cover.
1 mark. Tell me which flap.
Team
Team
A. Team A.
What is the flap of your choice?
KGMU
Sir,
Lucknow.
yes.
Your time is going on. Please answer.
Fast.
PTA
Team B.
perforator waist, sir. PTA perforator waist propeller flap, sir.
Propeller flap. From which side?
Sir, up.
Which vessel perforator? Vascular axis?
Sir, PTA waist.
Posterior tibial.
Sorry, sir. Peroneal waist.
Peroneal waist.
Yes.
So do you think that the peroneal side is okay?
Sir, I will check first with the handheld Doppler, sir. Then I will do.
You can see the picture
Yes,
of
sir.
the peroneal axis as well as posterior tibial axis. The third picture on the right. First and third. Your preference will be peroneal perforator?
Sir, PTA looks much better, so then we will go with the PTA perforator waist. Propeller.
Full form?
Posterior tibial artery perforator waist.
Okay. How will you identify that?
Sir, my reference axis will be from head of the fibula to the lateral medial line, and it lies the 2 centimeters.
No, I'm asking you which technique will you use to identify perforator?
Sir, using handheld Doppler on the axis.
Handheld Doppler. Okay. So, which flap will you prefer? Constituent of flap. What will be the constituent of flap?
What is the composition of flap?
Fasciocutaneous flap.
What are the other options?
Sir, is this a same question or different question?
Different question. I've given
So
2
how
marks.
many
2
marks?
marks. I've given 2 marks for the first question.
2
then
marks. So
team-
the question should go to second team.
So what are the other team B? What are the
Team
other
B.
options of constituents?
Sir,
Composition.
adipofascial flap.
What else?
Adipofascial or fasciocutaneous flap, sir.
Fasciocutaneous, they have said already. I'm asking any other option?
Any other options you can tell? In
Based
flap.
on the same
Same
perforator.
Muscle
Muscle flap.
flap. Like the
Based on the
versus-
same perforator. Listen to question. Based on the same perforator, which other composition? Okay, I give you 1 mark for adipofacial. Now team A, how will the flap reach?
Sir, after islanding the flap, I will give it a propeller motion. Then the flap will reach here.
Do you
I will
think
do
that
the
the posterior,
planning
do
in
you
reverse
think,
first.
just listen, do you think that the posterior tibial perforator based distal perforator with flap will, you will be able to take there as an propeller flap? Or something else?
A full 180-degree rotation would not be required. Um, maybe a 90-degree rotation of the flap will be able to reach the defect.
But the defect is in the tendo Achilles and you're raising flap from the calf area. 90-degree will take him nowhere, either 3 o'clock or 9 o'clock, isn't it? 90-degree will allow you to take the flap to 3 o'clock or 9 o'clock. This is at 6 o'clock.
I will transpose it.
No, dear. Transposition theory is something else. Team B. Method of transferring the flap.
The time is up, sir. Sorry to interrupt. 10 minutes over.
Okay.
How much mark will give for team A
No
for this
marks.
last question, sir?
Last question 1.
1 mark. Sir, because only one more question can go to team B. One direct question can go to team B to match the thing. So can you ask one direct question to team B?
Okay. So suppose you have to take the fasciocutaneous flap from the inferiorly based fasciocutaneous flap. So what will be the advantage of the fasciocutaneous flap over the facial flap?
facial flap will require grafting over it, while same is not there for fasciocutaneous.
Any other advantage or disadvantage?
Bulky. The flap will be fasciocutaneous flap will be bulky compared to adipofacial.
Will be?
Disadvantage.
Fasciocutaneous flap will be?
Bulky compared to adipofacial flap alone.
I couldn't get you. Fasciocutaneous flap will be what?
Bulky, she's telling.
Bulky. Bulky.
Yes.
Okay. So bulk may be there, but there is no problem of bulk there, isn't it? What is the purpose initially asked? What is the requirement?
Gliding of tendon and
Function. Glide.
function.
Isn't it? Okay.
Yes.
Okay. I give you 2 marks.
How much? 2
2
marks.
marks.
Okay, so that brings us into the first quarter. Just one more question is pending for Dr. Ashish. Dr. Ashish?
Yes.
One question is pending for team A. Could you make it quick so that it will balance the questions posed to both the teams?
Okay, team A. So this is what sir asked about a flap, which is a local flap. Do you think you can plan a free flap here? And if a free flap, which free flap?
Sir, yes, sir. Free flap can be planned here, sir. After checking the patency of the donor vessel, we can choose anterolateral thigh flap, sir, based on lateral circumflex femoral artery descending branch.
Okay, so why not just because we don't have much time? Try
Would you
to
like to pass
compare
the
it.
question, sir? Would you like to pass the question to other team, sir?
Yes. So other team, the same question. If I don't want to do the ALT flap for some reason, then another free flap, which can be gracilis flap. Okay.
Okay. How much mark will give?
So 2 marks to Gangaram team and
No,
one.
this is a past question. This is a past question for 1.
Yeah, pass. And full marks to KGM.
Oh, if full marks to
Sir,
KGM,
if
then
it is correct, we cannot pass to the other
we
team.
cannot pass.
Yes.
If it is
Okay.
correct, we cannot pass. Sorry,
Okay.
Gangaram. So
One
full
mark.
marks to KGM for this question. Okay.
Okay.
All right. So that brings us into the first spotter.
Sir, better you verify the marks with judge, sir. This
Yes, sir.
little confusion is there for direct and passed questions.
Yes, madam.
For spotter one, so that the next spotter it will be clear.
Okay,
So,
sir. Meanwhile, we can start the second spotter. I will talk with Bhattacharya, sir, and clarify the
yes,
course.
yes.
Okay, madam. Okay, so we'll go for the second spotter.
Welcome, doctors.
Please
Am I
carry on,
clear?
Balak.
Yeah,
Am I
you are
audible?
very clear, sir.
Am I
Please.
audible?
Yeah,
Okay.
you are audible.
Okay, we'll move on with the just read. Now we'll start with the second team because they are going to get the second spotter. They will be the first team to get the question. Okay.
Yes, sir. Yes, sir.
Okay. Now, girls, just read you have seen these pictures and as well as there is a little history is over there. What is your clinical diagnosis? Just seeing from this picture. Clinical diagnosis. You can give a differential diagnosis later. Most probable clinical diagnosis.
So most probably we think that it could be malignant melanoma.
So malignant melanoma. Okay.
Yes.
So that is your diagnosis, malignant melanoma. So what are the picture or why you are saying this malignant melanoma from this 2-line history to support your diagnosis?
Sir,
If you're not answering, we will pass on this question to the next team. From that 2-line history, what is that supporting your diagnosis of melanoma?
Slow growing since last 1 year.
1 year it's growing. You think melanoma growing 1 year? Okay, next team.
Since
I think,
my
I
diagnosis.
think Dr. Balakrishnan,
Yes.
No,
take
it's a
little
pass
time.
It's
to
a past
the team
question.
1.
Now I'll give the mark at the end of this. Okay.
Yes, sir.
Yes, sir.
Okay. This is a past question to the team B.
Yes.
Team A.
Yeah. Whatever now the reverse.
Yeah, KGMU team.
Yeah.
Sir, my
Team B.
clinical diagnosis will be basal cell carcinoma, and point in favor of basal cell carcinoma is the slow growing over the sun exposed area. As well as over the H region, it is more common with the round edges, rolled out edges.
Clearly, what is your point and what kind of edge you are seeing there?
So rolled out edges, it's seen.
That is not rolled edges. Anyway, it's a clear edges are there and clear margins are there, and you can see that
Typical appearance.
Typical pigmentation, everything. So team A, the first one is not getting any mark, and team will getting
Team A gets the passed out
0.
question, 1 mark.
The other team will get the
B
1 mark
0.
per pass question. Now
Yes.
we'll
Yes.
start with the team 2. And now considering this, I'm adding one more point.
Sir, now it is KGMU direct question, sir.
Okay, right. KGMU.
Direct
For
question.
you. Okay, we'll come there. KGMU, this is a direct question. Suppose this patient has a lymph node that is there present, and in which region for the forehead area you expect the lymph node to be, and where will you look for that particular lymph node, which lymphatic basin or lymphatic region you will look for in clinical examination for that forehead, and for that intratracheal and pretracheal lesion. In other words, please tell me about the lymphatic drainage of the face.
So the pre-auricular regions are
For which one?
For the tragal lesions, and
For the tracheal lesion, it is pre-auricular lymph node. Okay. That is the first group of lymph nodes which is supposed to get its drainage, right? For forehead. Forehead.
Sir, 1 minute over.
Yes, pass on to the next.
Team B.
Team B.
Sir
The answer is
Rangaram.
first. Just say, what is the lymphatic drainage of the face? Which group of lymph nodes and how do they drain? This is a simple basic anatomical question.
Parotid lymph nodes.
Which one drains, or which part of the face drains into the parotid lymph nodes, and which one drains into the... There are three group of lymph nodes, right? One, how does the pre-parotid or the parotid group of lymph nodes is an outlying lymph node, okay? So there are other group of lymph nodes which drain. What is the face lymphatic drainage of the face?
The parotid lymph nodes, the
That is what
submandibular.
the team said. What about the other lymph nodes which are supper, and how do they drain? What is the facial division, or some kind of an imaginary line that can say that you can say that this area drains into this one drains into that one? Okay, you are not answering. So at least KGMU, they get the mark 1 and 0 for the second team. Okay. So I'll come to the answers and I'll give you all the answers at the end of this question hours. Okay. So I'm giving you an extra clue that this patient doesn't have this direct question goes to the team. That is
Sir Gangaram.
Yes. The patient doesn't have lymph nodes palpable either in the pre-auricular region or there in the submandibular region or in the level 2 lymph nodes. So what is your most probable diagnosis and why does it occurs in that way? Direct question to Gangaram. Please answer first. There are no lymph nodes palpable in this region.
Basal cell carcinoma.
Why? Why in basal cell carcinoma? Usually they don't have the lymph nodes.
Yes, sir.
Is a direct question to Gangaram.
Because it is locally invasive, sir. It does not.
Locally destructive. It,
why does it
generally
doesn't spread to the regional lymph nodes?
Yes, sir.
Usually it doesn't spread to the regional lymph nodes.
Yes,
Why?
Okay.
Okay. The team B. The other
Team A. KGMU.
It's a past question.
KGMU.
Last question, sir.
Yes.
Last question. How much was the score, sir? Just sorry to interrupt.
Previous
0, sir.
0.
0 for both the teams.
0 to Sir Gangaram. 1 mark to KGMU.
Okay, sir. This is the third question.
Now,
third question. Maybe that question. I don't know.
To KGMU.
Okay, sir. Please continue.
Okay. Now KGMU has now passed on
Second question.
Yeah. Why the BCC usually doesn't have the lymph nodes? What are all the reasons?
There is due to the locally aggressive nature of the tumor, the lymphatics are vessels are destroyed. Hence, there is no lymphatic drainage there is no lymphatic spread in case of BCC.
Okay, good. 1 mark for KGMU for the passed on question. Now the next question we'll begin with the direct question to KGMU. Yes, what is the cell of origin for this BCC? What is the cell of origin?
Suprabasal keratinocytes.
What is that?
Basal cell located in the stratum basal.
No. Next one. Gangaram. So based on that, this tumor has got another name. What is the other name for this?
Rodent.
BCC has got another synonym based on this cell of origin.
Rodent ulcer.
What is it? What is it?
Rodent ulcer.
Dental cell. What is it? Come again, doctor.
Rodent.
Rodent cell. Maybe this is called rodent ulcer. Okay. So that's a different thing. Both of them are not getting the correct answer. We'll go to the direct question to the Gangaram. Okay. So what is the non-invasive investigation now, which has come as a recent advance to know the clinical diagnosis or to confirm the clinical diagnosis? It's a totally non-invasive investigation. which will confirm the diagnosis, your clinical diagnosis. What is that? I think there's a direct question to Gangaram, right?
Yes,
Yes,
sir.
sir.
Yes, answer that. The third question, both of them had 0 only, sir.
Correct, sir.
Previous question. Cell of origin.
Correct, sir.
Now you answer this question. Gangaram.
So laser Doppler for vascularity.
Doppler. What is that going to tell you about this? How do you diagnose this? Okay. Team KGMU.
Sir, I will go for the small lesion excisional biopsy till the reticular dermis.
Non-invasive.
I said non-invasive. One
Dermoscopy.
non-invasive to confirm the diagnosis.
Dermoscopy, sir.
Very good, very good. Give them 1 mark.
Good.
Okay.
1
So
mark.
in the dermoscopy is an additional question for you. And dermoscopy, hello, Gangaram, this is a direct question for you.
No, now the question, direct
Now
question
the
will be for
team KGMU,
KGMU.
sir.
Okay, Jamie. Okay, direct question for you. In dermoscopy, what is the feature to confirm that this is a BCC and not malignant melanoma or nevus sebaceous? These are differential diagnosis, no? So what is dermoscopy? First, describe what is dermoscopic examination. Describe what it is.
The binocular instrument through which you can see over the skin in magnified view.
What is the typical light that is used by the microscope? You are getting a magnified view of the cells of the skin surface, but there are certain things can intervene with your image magnification and identification of the structures from the surface. So they have done some kind of special light. What is that light being used in that? In the dermoscopic examination. It's a totally non-invasive. Gangaram?
No, sir.
It's a passed on question to Gangaram.
No, sir.
Okay. Both the teams getting almost 0 for this. Okay. Now this is a direct question to Gangaram, right?
Right.
Okay. So, for example, there is one technique which is surgical technique available for this, especially these are all in the aesthetic units, and we have to spare as much as non-involved tissue, but we have to excise completely all the involved tissue with the tumor-free margin. What is the technique that is being now used? Which can be
Mohs micrography surgery.
What is the previous name for this one? This surgery. It has been now improved version you are talking about. Mohs micrographic surgery.
Yes, sir.
What is the previous version and what is the present version and what are the main steps in that Mohs micrographic surgery?
In the original version, he used to apply a keratolytic, that is chloracetic acid, and then he used to apply zinc chloride. And
very good,
then
very good. What is the name for the surgery at that time? You are applying some chemical. I'm giving you the clue. Okay, now what is the technique now? You tell me the steps. Crossly the steps. Mohs micrographic surgery.
Sir, now we do bread loafing of the lesion, and
You do bread loafing.
and we observe it after orienting it and mapping it. We observe it under the microscope for the involved layer by layer.
Your answer is not up to the mark. Give them the 1 mark, sir. The next passed on to the
Sir, already given Mohs micrograph 2 marks. So KGMU should you ask a direct question?
No, that is a total question, madam. That is, they answered half. So there is something else, steps of that Mohs micrographic surgery. They didn't come with that. KGMU, you can answer that. You can get the rest of the 1 mark if you were correct. At least basic steps of that one. Mohs micrographic surgery.
Sir, after debridement of the tumor, we will take the beveled knife with a 45-degree angle and take a slice horizontally, and then we will press it and do the fixation, and then
How do you fix? How do you fix? What is the specific technique used for most micrographic surgery?
sir, we will fix in a 4 quadrant, 3, 6, 9, and 12 block.
Quadrant okay, color coding okay.
Then
Fixing. You need to make a slices. For that, you make it hard. That is called fixation. How do you do that?
The
We used to
cryostat
do set
microtome.
and the zinc chloride, but now what are they
So
doing?
we use the cryostat microtome.
That is right. But before using cryostat microtome, what is the technique for making it hard? Okay.
zinc chloride with sanguinaria and stibnite was used previously.
That is okay. Now, what is this frozen technique? Mouse, I gave the answer. Give them half mark. Okay, there's a direct question.
No half marks, sir.
No
1
half
mark
mark.
or 2.
Okay.
A consolation.
this one-
Just give them 0.5.
No, you ask a direct question.
Half of the
1 mark
questions they have answered. After
1 mark. 1 mark.
Okay.
So
One
one more
Ask
question.
mark
direct
is okay. 1 mark is okay.
Yeah.
One
Okay.
mark. That means this question, 1 mark, both the teams get.
Yes.
1
1.
mark to both.
Both.
Both. Okay.
Yes.
Now, a direct question for KGMU. That will be
Yes.
the last question.
Yes. So if it is going to be a melanoma, what kind of a clinical type it is going to be? Which is the most common type of melanoma which occurs there in the face, especially in the sun-exposed region? There are 2 common types. You have to tell that, at least 2.
Superficial spreading type, the most common melanoma.
I am talking about clinical types of melanoma or clinico-pathological type of melanoma. I'm not talking about PCC. KGMU?
Lentigo maligna and
Yes.
superficial melanomas.
Okay. Give them 1 mark. Next team. What is the
Sir,
other clinico-pathological variant which is
sir,
very common melanoma type in the face?
Yes. Balakrishnan sir, time is up, sir.
Okay. Then.
Only that passed on question, Sir Gangaram, please answer
You
that.
just answer, we'll finish up this.
We'll finish that.
Okay, sir.
Sir Gangaram,
Answer first.
the variant
What
of
is-
BCC, which is common in
Not BCC, melanoma. They said one
Melanoma
lentiga
like,
maligna. Lentigo maligna. And what is your second common type of clinico-pathological type?
It's a nodular
Melanoma,
type
which
of
is there seen in the head and neck region. Okay. So just because I have finished now, shall I give the answers for whatever the questions I have asked for so far?
Yes, sir.
Yes,
Please
sir.
give it, sir.
Okay.
Just 1 second.
What is the
Gangaram gets any
answer?
mark?
Gangaram,
Gets
So
mark?
answer what
They are
is
not
the
getting,
we
they are
said,
not getting
nodular-
mark. They didn't say anything.
Okay,
not
sir.
So we said the nodular type.
No.
Of,
I'm not asking about the clinico-pathological type of BCC. I'm asking about clinico-pathological type of melanoma in the head and neck region.
Okay, sir. Sir Balakrishnan sir, you can tell the
Melanoma.
answers now.
Yeah.
Time is up.
Yeah. So for the benefit of remember that it is the cell of origin for the BCC is always the outer sheath of hair follicle. That is why it's also called a tricholemmal cancer. Okay. And remember that the histopathology is that as a palisading, mainly palisading, the group of cells, they have a highly desmoplastic reaction and they are all causing local destruction and they shuts off the lymphatics. This desmoplastic reaction of the cells. Therefore, the lymph node drainage is shuts off and therefore the lymph node very uncommon in the PCC. Suppose you get the lymph node in the presence of a PCC-like picture, you must think about basis squamous carcinomas. Okay. The next thing, the lymphatic drainage of the face, you have to have the central area of the face. You draw a line slanting through the angle of the mandible and the medial 1/3 and lateral 2/3 of the eye. The medial area, the central area, everything gets drained there into the submandibular group of lymph node, whereas the posterior to this line, they get drained to the preauricular outlying group of lymph node that is there called as a parotid group of lymph nodes. The center of the lower lip, the tip of the tongue, they drain into the submental group of lymph nodes. So this is a facial lymphatic drainage. Okay. So most micrographic surgery, the steps are like this. First of all, you have to remove all the hypertrichotic or hyperkeratotic plaques which are there, debride that, and then using the tangential excision with a 45-degree angle, you have to take multiple slices, color code them, divide into multiple quadrant, freeze them. It's a frozen section, okay, before using the cryostat to cut them and then make multiple slices and then fix them. And then you have to go in for reading under the microscope after staining. So all these things are all helpful in getting so previously it's called zinc chloride injection. That's why it's called the most chemosurgery. It's previously called most chemosurgery. Now it has been called as most micrographic surgery. Okay. So that is the essential steps you need to know about that. And these are all the answers, I believe. Anything else I have left out? Any other question which I have asked, which I am not telling you the answer?
Nothing, sir.
You were answered, sir.
In view of time, we'll go to Judge Professor Arun Chaudhary, sir, to ask his question.
Thank you, sir. Thank you.
Thank you, sir. Thank you,
Thank you,
Balakrishnan,
sir.
sir.
Okay, best of luck to the team too. Just have about 10 seconds. Go through what already been asked by the panelists. I hope I will not repeat the questions. Mostly I will ask little very easy questions rather than the panelist. So already we have talked about what are the types of basal cell carcinoma and what type you are having in this patient.
Sir Gangaram.
Team 2 I am asking.
Sir Gangaram.
Sir Gangaram Hospital. Dr. Nishta and Dr. Rishika. Any of you?
Superficial spreading type, nodular type.
What are the normal types of basal cell carcinoma? Clinical types.
Yes, you are telling. Tell.
Yeah, you are telling rightly. Just go ahead. Quick. We have a time limit.
Quick,
no?
because time will go, na?
Adenosystic type, adenoid type. And
have you gone through the normal of our books? Grave and Smith?
What you told initially, they are correct only. Why are you hesitating?
Hesitating. Just you have gone through that book, I think.
desmoplastic type is there.
Okay, I will tell the answers afterwards. But anyway, you are up through.
Pass it to team
You have
A,
only
sir.
1 mark, you get it. If I pass in, you have 1. Next team 1. Can you answer?
Sir, the basic type of basal cell carcinomas are superficial spreading, nodular type, morphiform, and
what is the other name for morphiform?
Morphiform is invasive basal cell carcinoma.
No, what is the other name given very commonly?
Sclerosing.
Yeah, very good. Anyway, you get the full mark. And what type of this? He gets the full marks. 1 mark. That's the full mark. Then the next question goes to the team 2.
KGM.
KGM, sorry. What are the predisposing inheritant syndromes associated with basal cell carcinoma? Could you follow my question? Or I will repeat my question.
Nevoid basal cell carcinoma or Gorlin syndrome.
Yeah.
The Vejex syndrome.
Yes.
Xeroderma pigmentosus.
Xeroderma
pigmentosus.
Pigmentosum. Okay. Anyway. Then anything else? Any other syndrome associated? Okay, I'll tell you. You got actually, I think you get the 2 mark for this because you have told majority of the. And then I go to the team 2. What is now in this case, what will be your planning for doing excision and also the reconstruction? What is your planning? Planning means it goes to planning in reverse.
Surgery.
Surgery I am talking of.
For excision parts, huh?
Yes.
For excision in basal cell carcinoma,
We are
in
focused
this
on this
case,
patient. This patient only. Okay.
this patient. Okay, sir. Since it looks like more than 2 centimeter lesion, and I would like to treat her as high risk and take around 4 to 10 mm margins around the
4
lesion.
to 10. It is either 4 or 10. It cannot be 4 or 10.
So 1 centimeter, 10 mm margins. I'd like to be safe, and I'd like to excise 10 mm margins around the lesion. And
okay. It is in the forehead. What about the preauricular region? There also you want to excise this much?
yes, sir.
So what is the basis on which you have to excise? What is the pathological basis on which you tell this much of margin I will excise? Is it 0.2, 0.5, 0.6, 0.10 mm, or what is the basis on which? What is your whole purpose of doing this excision? Taking the margin. Okay.
Basically to prevent the recurrence of the lesions.
So you want a tumor clearance. The margin should not have any tumor.
Clearance.
Whatever
Yes,
this.
sir.
So that is the point. Okay. So if you have the facilities, you can see that the normal skin are there. The tumor tissue is not been involved. Okay. So that is the purpose. So it will range from 0.5 mm to 1
So
centimeter.
how much score to give? How much mark to give, sir?
Sir, 1.
Direct.
1.
The next question is direct question for Gangaram.
Gangaram, we have a direct question for Gangaram.
No, KGMO.
Sorry, KGM, sorry.
KGMO.
In the preauricular region, suppose you excise it and you find a defect. So what is your planning? How do you reconstruct it? Gangaram?
You can
Sorry,
do the trapeze.
KGMO.
Rhomboid, sir, rhomboid flap, you can, after making the defect in a trapezoid manner, I will go with a rhomboid
What
flap.
type of defect you are going to make? After excision, what will be the defect? Is it apparent defect or a true defect?
After making debridement, it will be the true defect.
Not debridement. Here you are doing excision.
Excision.
Yeah. It's not a debridement, it's excision. So what defect will occur after excising the tumor with the margins? What defect it is called in plastic surgery?
It will be the true defect.
Yeah, true defect. So for that reason, you do a planning in reverse. So
Yes.
what planning in reverse will do? How do you do it?
Sir, I can go for the posterior auricular artery-based flap or the rhomboid flap in the local.
You have to
from
do
the
one.
local way.
Suppose you are given choice of one.
The first
flap.
choice will
You
be
are
the
told post-auricular. What could be the flap that can be taken from post-auricular region without a defect? We can close it primarily. Do you know what is a bilobe flap?
yes.
Sir,
So what is a bilobe flap?
Do you want to
In
pass
this
the question,
two
sir?
semicircular.
Okay, I pass on the question, I think, to the next. You get half of it. You get only 1 mark. Next.
Yes, sir.
Team 2, can you answer fully whatever I wanted that? What is a bilobe flap and how do you design it?
The bilobe flap design, sir. Basically, it is a type of transposition flap where we create two lobes, one to fill the primary defect and another smaller lobe to fill the secondary defect, sir. For the designing and planning of the flap, we have to mark the circumference of the lesion, and we have to add 45 degree to the we have to mark the diameter, and at 45 degrees from that diameter, I want to create another lobe of the same radius. And at another 45 degree, I want to create a triangular lobe, which is smaller compared to the previous lobe. And I transpose the second lobe to the primary defect, and the triangular flap for the secondary defects.
So what about the second flap? Do you have a defect there? How do you close it?
It is closed primarily. We close it primarily.
Okay,
Sir.
thank you. I think you have answered well. You get the full mark.
One more, sir. Time is up, sir.
Yeah.
This process shows, sir. Time is up. Both got equal number of questions.
Yeah.
So I think both spotters are over now. So, madam. So we have Dr. Umar Harris not there. So let us.
I think we will take feedback from faculty and the panel.
Dr. Rohit, please
yes.
take the feedback. Let me collect the scores.
Yes, sir, sure, sir. I would like to take feedback from our panelists.